is about 300 minutes. And by this time, the time we have been here, we have lost about 150 mothers. The time we have been here alone, 150 mothers have already passed on because of pregnancy-related complications. It's a big problem. It's a big problem. You can't imagine that if we put coffins in this house of 150 mothers, how sorrowful can that be? And that's what we're talking about. That's how big the problem is. So that's the thing we're talking about. And we are not very far from the Agenda 2030 with our SDG 3, where we want to see that the mothers at least below 70. But we have countries in the world that are still having 500, 700 deaths per 100,000 live births of mothers. And that's a very huge problem. None of us likes to lose a beloved one. None of us. It can't be your mother, it can't be your sister, it can't be your auntie. None of us likes it. So that's why we are here to see how can we solve this. So a few of them, when we talk about maternal mortality, is a mother dying due to pregnancy or pregnancy related. It can be an abortion, it can be during birth, it can be after birth, as Dr. Aklo was telling us, up to about 6 weeks of past delivery. And all this period, what have we done? What are we doing? Okay, so how many mothers do we lose per 100,000 live births? How many do we lose? And it's not only in sub-Saharan Africa where the burden is, even here in Canada, 12 mothers per 100,000 die. And actually, we need also to look into it, because it's not only outside us, it's not very far from us. Even here, seeking health is not an easy thing. If you met the new people who are just coming, the new immigrants, what they go through to access health, it's not easy. Why? Number one problem, do you have the information? Do I have the information? No. And by the way of information, even we don't have enough doctors in the country. I'm lucky, my wife delivered 4 months ago. We are able to have a specialist to attend to us. But up to now, she has never received a specialist review. It's supposed to happen after 6 weeks. By the time she delivered, the doctor was booked for over 2 months. Fully booked for over 2 months. How can we change such? How can we change such? That's what I have to see today. So for the infants, for the neonates, we have seen all that for the under 5 and for the children. So, quickly, the status quo I was talking about. Globally, every 2 minutes, a woman dies during pregnancy, childbirth, and in 2020, this was estimated to be 287,000 deaths worldwide. 287,000. That's more than 250,000 people dead, mothers alone, because pregnancy related. And that's according to the UNICEF report of 2022. It's not way years back, it is now. This is not history. That's what is happening now. How about the babies? How about the newborns? How about the children? Every day, 6,300 babies. Every day. Every 24 hours, 6,300 babies. We lose them. Within the first month of life, those have gone. And in 2022, we are able to lose, by 2020, we are able to lose 2.3 million newborns. 2.3 million newborns. Those are the future doctors, the future ministers, the future engineers, the future everything. 2.3 million gone. You know, when you talk about the numbers, when you speak about the numbers, we don't feel it. But an accident can just happen. Like we're back in Africa, we have a lot of truck accidents, and 7 people die, and you see how people are devastated. But I'm talking about millions of children dying before they make their first month in life. And it's happening now. 2022 is a year before last year. And these statistics have not changed much. But we are on the agenda of 2030, where we're supposed to have almost down to this. But I'm telling you, it's a huge problem. Because you can't tell me that we are going to be there by the time it comes to 2030. We have about 5 years from now. We have spent a 10 already, but here we are. This is what we're talking about. This is how big the problem is. So that is that pictorial program shows you our Sustainable Development Goal, the SDG 3, that talks about good health and well-being for every age group, for each one of us. But I will be talking about mostly about the mothers and the children. So it should ensure healthy lives and promote well-being for all at all ages. How will it be by 2030? Will we be there? It's me and you to answer today. So the maternal mortality ratio, we'll talk about that. We'll talk about the deaths of mothers who have passed on amongst the 100 live births. How many die? That's the ratio or the rate. And by 2030, that is our target. This is where we are supposed to be by 2030. That we are supposed to reduce the global, not national, not country, global maternal mortality ratio to less than 70 per 100 live births. That's the target. And we are 5 years away to assess whether we are reaching this target or we are not reaching it. So this picture is not to be so clear to you, but these are the numbers as per country of mothers who die. Dr. Aklo told us in Uganda, we have just come to 180 what? 80 something. We were in the 300, we came to 200 mothers per 100,000 who die because of pregnancy and related conditions. So in the world, if you look, like in Sudan, 730. Like in Sudan, 730. So if you're 730 in Sudan, how will you come to 70? DRC, Congo, 500 and something. When will you come to the 70 in 5 years from now? That's where we are. And that's how the picture looks like. Okay? When you see those colors, the darker the color, the more the deaths. So the darker the color, the higher the mortality, as you can see. And that's how it is by the end of 2022. That's where we are. So what we're talking about is not far, it's not in the history, it is now. It's still a very big burden. And that's what we are called for. How can we tackle this? Which approaches can we bring to see that we can reduce this to less than 70 per 100,000 deaths? The same applies to that. So you can see that the darkest color is above 750 deaths per 100,000. That's the darkest color when you look at that map. And you can see about the color, where is the major problem? Sub-Saharan Africa. Sub-Saharan Africa. So it contributes over 80% of this burden, whether for children, whether for mothers, over 80%, everything is there. What can we do to improve on this? That's what we're talking about, that every 2 minutes, a woman dies. Every 2 minutes. If you have been here for 5 hours, 150 women have died. 150 have died. It's so sorrowful. So sorrowful. But we don't want to be losing them at that front. And our target is that we need to, this is for children, we need to end all preventable deaths under 5 years of age. All preventable. Some of these deaths are preventable. We have seen the determinants. They are preventable. Can we educate the women? Can we work? Because it's not a one-man show. It's a collaboration of many sectors. How can we handle this? So, will we be able to reach the under 5 mortality by 2030 to be less than 12 per 1,000 live births? And in 2020, an estimate says 5 million children under the age of 5 died. 5 million children. Do we know the population of Ontario in Canada? The Ontario has the 5 million people. You will be surprised. It may be like 4 million. Now, which means like, if this million children, that means the whole Ontario was swept off. Can you imagine if you had a flood and like a province big as Ontario is swept off and no one is living? It can be devastating, but because one dies somewhere and we don't see them, we may not feel the burden. But it is a huge loss. So approximately half of those deaths occurred among newborns. That's less than 30 days on this one. 2.4 million, which means almost a half of them. So from the day a child is born to reach 30 days, 50% of them may be gone. Which is so devastating. Mothers go through a lot when they are carrying these pregnancies. And if you have been in healthcare, you see them. If you have never broken news that we are sorry your baby died when we are pushing this baby, you may not know. Some of us, we have been there. And we know. Actually, I tell people, the first day you enter labor suit, that's when you go back and appreciate your mother. The first day you enter labor suit, deliver, or to attend to a delivery, that's when you go back and thank your mother, because they go through a lot. But to tell a mother that your baby has gone, 9 months, with all the issues doctors were telling us here, you don't want to eat, you want to eat, you're hating your husband, you don't look at your husband. So many things go through. You are vomiting, and now all of this. That's why they become depressed, they get mental depression, they get psychosis because of such issues. It's not easy if you are losing such a number of babies when they're just born. So children in sub-Saharan Africa, we have the highest mortality, of course, and 74 deaths per 100,000, which is 14 times higher than the risk of children in Europe and North America. So where we are just lucky that we are a bit better, but we still need to, because whatever happens elsewhere affects us. So the gist of the thing, innovative approaches. Which approaches can we employ to bring down these mortalities? What can we do? What do you think can we bring on board? What can we do? So we want to look at how these approaches can help us to improve the access to healthcare, because it's a major cause of these deaths. The access to healthcare. So we are looking at things like mobile health or technologies. If we embrace the mobile health technologies, can they help us? Are they able to do something on this burden? So I want to tell you that one of them is telemedicine. And telemedicine is that I may not be here physically, but I'll be able to help someone who is not here. How can this work? Because we have remote settings in every country. Back home in Africa, we have remote settings, whereby in the community, there is no hospital. Or what is there is a community health worker, what is there is a health center that cannot handle a big problem. Do we have, in such a country, maybe at a regional level, a teleconferencing place with doctors 24 hours, 24/7, waiting to help someone who needs an assistance down there? Because I can be far, but I can instruct a midwife, I can instruct a nurse. What can they do in that place? Because if a mother is bleeding, you have less time to serve them. Yet there are simple things you can do to serve them before they reach a hospital. So in an era where we have technology, if we can embrace telemedicine, and we have a region set, and we have people who can help down there, I believe this can help us to cut down some of the preventable deaths of our mothers and our newborns. So this can help us help us with healthcare providers consultations. It can assist in monitoring pregnant mothers, and can help in giving advice, and can help also in instructing health workers. So we have the apps. In some countries, I've tried them. Most of these I've heard them so common. They're being used in South Africa and developed countries. So we have the Momo Connect, the Mama Text Messages, the mobile phones, the Como Care, the Child Connect. These apps have been developed to give one, information, and two, to to regularly remind the mothers that you need an appointment. You have an appointment. If you see this, please come and be attended to. So these have some success, though there are still challenges within them. But if we can embrace them, if as we saw, that one of them is also policy, government policies and laws, they affect us. If our governments can come and embrace them and invest in such, I believe we can be able to reduce this burden of maternal and child mortality. So they can provide information on prenatal care, on symptoms during pregnancy, and reminding mothers about antenatal checkups and vaccination schedules. So Dr. Su was here. I remember a number of years ago, I was in a hospital, and this mother comes for antenatal care. I was leaving because it was lunchtime, and I was still a student actually. And this mother comes, and I never wanted to examine her because I was leaving. But she insisted and said, okay, let me examine you. In the issue, she told me she was never told me that she had been operated before, I never had a Caesar before. So in my examination, I find a scar on the abdomen, and I ask her, were you operated? She says, yes. Where is the baby? He says, I lost the baby. What caused the death of the baby? She said, I don't know. I said, how can you not know? She said, it was an emergency. And she was attending medical care in the National Hospital in Uganda. So she said it was an emergency. I just went to the hospital. My doctor was not there. They pushed me to the theater. They operated me, but the baby had died. Now, when I dug backwards, the issue was in all her antenatal care, she had never been told about danger signs in pregnancy. So she began seeing that the life was coming out like 4 days back, and she never bothered. Because she never knew. She said, this was the case. They told me when I see blood, I got to hospital. But this was water just coming out. Now, probably the baby got an infection. By the time the baby reached the hospital, it was no longer there. So I think that got pneumonitis and was not able to survive. Now, this mother tells me, and was so, I said, what? You are not told this? She said, I never heard about this without my attending of the hospital. So I had to cancel my lunch. I sat her down and told her, you can imagine, as a student, she refused any other doctor to ever touch her until she gave us that baby. Even when the time for the delivery came, I was a student, she refused and told me unless I show her the right specialist to deliver her. You see that information is key. So if these apps can give mothers the right information, we can prevent some of these deaths. We can prevent some of these newborn deaths. By the time they don't have the information. This was her first pregnancy that she lost. And this was her second pregnancy when I met her. So just information. But if somebody can have an app and it tells you, when you see this, go to the hospital. When you see this, go to the facility. This can be a saving point for them. So I believe if we embrace such technologies, we can be able to save some mothers and save our newborns. Another one is community health workers. Some countries have done this, and it has worked, because these are trained. Unfortunately, in Uganda, if you come from Uganda, we have heard about village health teams, VHTs. It's a very common term used there. Unfortunately, the people who are will be the community health workers in Uganda, they're not trained health workers at all. They just pick someone at the village and they bring them. I've seen them, some of them are even over 50 years and they have never been to, and they have no formal education. They would do a great work if they are well trained into this. Why? What can they do? If they are trained and they're deployed, they can be a great resource. So the community health workers, if they can be embraced and enrolled, they can help us to be able to refer the mothers early, to do home visits in the community, and to do health education to the mothers, because they are close to them. And if we want information, the reason why, in Africa, we are still having the tradition of birth attendants, and the mothers still trust them, is the closeness they have with them. They see them every day. They go to the same place to fetch water. They are in the same village meeting, so they feel that they are secured to get them information and take you the health worker whom they don't know much about. So if we have these community health workers positioned in the communities, I believe we will train and given the good tasks, they can help us to handle some of these issues. It's like health education. We shall see when it comes to mobile clinics and those. These can be a great resource, but a number of us, we haven't embraced them. It becomes hard for the mother to move or to come to us when there's no one in the community they can run to at the first instance. The health education, that's what I talk about, the information. It is very key, but many times our mothers don't know what they're supposed to know. And it is very important. And these community workers can do this. They can refer to health facilities, and they can bridge healthcare gaps. So, another scenario happened in 2022. I was on night duty, and it was around 2 a.m. in the night. A 2 previous mother comes. I've been operated twice before, and from a Mediocrity Hospital. Where does she come from today? From a health center 3, where there's not in the presence of a doctor. And why? The previous 2 scars, she said she had been told that she cannot deliver normally. But by the virtue of the information that the woman has been operated twice, you can't have them to labor, because you can easily rupture their uterus, they are going to bleed to death. Now, this mother, the health center 3, because I don't go to the hospital, be operated again. Why? Is not aware. Now, such people in the community can say, if you have any scar, please seek another care from a hospital. And they can follow up. Did you go to the hospital? What are you told? But it must be there, 1 scar, 2 scars, 3 scars, and wait to deliver normally. Because they have gone to a herbalist and they told them, no, we can change this. And this is information. But if you had community workers in the community, they would be able to remove these myths among the mothers. And they know, if you have been operated twice, you cannot deliver again normally. Go to the hospital. But you have such cases. Well enough, I was able to operate on her. The mother and the baby are all alive, and I told her, please, you never deliver normally. Because your pelvis, a baby can never pass there. And that's what we go through. That's what we receive. At night, I tell you, don't have any supplies. These are previous scars. You may not even have to run for blood. It's not even available. But what causes this? It's supposed to be an elective case. It becomes an emergency at night because information. So we have, if we train this work, I've said that they can be good. Community mobile clinics and outreach services. Mobile clinics and outreach services. We have the issue of topography. We have the issue of finances. WHO has got us from 4 antenatal visits to now 8 antenatal contacts. Ideally, if you look at this, it means every month you are going to the hospital. I can assure you, a number of countries in sub-Saharan Africa, they can't afford even a transport to go to any facility. So if they can't afford a transport, what can we do as the policymakers? What can we do as the advocates of maternal health? 1, can we have the mobile clinics? Can we go to the mothers instead of them coming to us? Because if you take a clinic nearby in the community, they will come. Actually, like in my country, Uganda, we are able to do most of the COVID vaccinations were done because of outreaches and mobile clinics. But when it comes to hospital to get the vaccines, no, we had to go to them. Why don't we go to the mothers? Why don't we go to the communities for mothers, for the children, for vaccinations, for antenatal care, for prenatal care? Why don't we go to them and tell them, you know what, mama, for you have been operated before, now from there onwards, please go to the hospital. You never don't wait for labor pains. If we set such clinics, they can be a great help to people. Because there are a number of things. Topography. Some of the areas are not easy to reach. And even if you had a smaller car, you cannot go there. So we need like strong cars to navigate such topographic areas. And if government and can have such, we can be able to reach to the mothers, the children, but not them coming to us, because it becomes harder for them to come to us, economically, topography, and the type of roads that they use. The outreach programs, they do the same, and I believe if we embrace such and put our efforts to them, we can save some mothers, we can save some children. Children miss vaccinations, and you know why? Because the mother, you know, like many people think when the children wants to be sick. So when you bring a preventive the preventive healthcare services, they don't come for them because they're not sick. They only come when they are sick. So if you want to give them the services when they're not sick, you have got to go to them. If you wait for them, they don't come. That's why children miss vaccinations. So how about the financing? Yes, the governments have done a great job. But where are we? The innovative financing. Are we able to incentivize our financing? Is our financing has incentives? What can push the health workers or people who are in the health sector to do more? So I'm looking at performance-based financing. We have had this project in Uganda, but the challenge is it has results, but no sustainability of the funding. And this was, if you deliver, the more delivers you make, the more money you make. Performance-based. The more children you vaccinate, the more money you get. Performance-based. And it had results. Because the health workers, the money we're getting, 40% was for incentives to health workers who are doing the job. And 60% was investing in equipment and infrastructure in the health facilities. So if you have such models, even the people who are working in the sector can be incentivized to do more. And I'm telling you, health workers were looking for mothers for family planning because of this incentive. You got to look for them because you know if I insert long-term plans like IUDs, each mother I insert, I have money on that mother. I have an incentive. And we are doing a great job. But if you just leave them, you have a salary, that's all. They offset the whole facilities. They want to go down there to help the mothers. So can we have such performance-based financing to come and help us? Health insurance schemes. Dr. Su was talking about this in the morning. The major problem is the economic status. Our mothers, including the fathers and the men, may not be having the finances to do this. Another nurse was talking about the insurance. So, can we tell these people about insurance schemes? Like, actually, I will tell you frankly that where I come from, in Africa, in Uganda in particular, there are very few of such schemes. Even me, I have never been in any life insurance scheme. As educated as I am. Because how many come to me about life insurance? Very few. You won't even see them. Actually, unless you go to a conference or someone happens to you in a bank, that's why they can tell about life insurance. Can we have community-based life insurance? That we have, say, a sub-county. We have a community, and they say we collect this money to help us when we need health care. If it is well taught to them, they can embrace it because they have embraced other schemes, though they're not life insurance schemes. So if we have such, and you know that I have my card, if I have a health problem, I go to the hospital, I don't need to pay cash, not out of the pocket I will be worked on, they can be a great saver to our mothers. They can save greatly our newborns and our children. So, can we think of health insurance schemes, community-based insurance schemes basically for our mothers and our children? I believe it can save a great. Integration of services. So you find that a mother is pregnant and maybe has a child to bring for vaccination. And health work at the facility gives you, this week come for antenatal care, next week come for vaccination. Why don't you give this mother the same date for antenatal care and the same date for the vaccination of her child? So that she comes once and gets twice of the services and she goes once. Can we integrate this? If a mother comes for postnatal care, why don't the first 6 weeks, why don't we take them for family planning? So that we don't wait for them to come back when they're pregnant again and we think of family planning. Can we integrate these services that when you come, we'll have a one-stop area for this, so that they don't come today and come tomorrow next week for different services. If we do this, we can be able to achieve something. Use of data analytics. I sincerely agree with you that we collect a lot of data in the health sector. But ask me, what do we use it for? And when do we use it? In Uganda, we have been. We have weekly reports, we have monthly reports, we have quarterly reports, we have annual reports. But what do they do? And when do we use them? So the man is going to die, the children will die, and they're doing the routine. Does our data inform us of anything? Do we have real-time monitoring and response due to our data? We collected of data. When do we use it? And how? Every week you report. And the issues reported, they ask, you are going to report. Where is the feedback? When am I called to discuss the data of my health facility? And how can this data inform me to change the routine that I'm doing every day? And I change about it. You just report. Those have been there, you know, we report. Health workers report, and they're demanded on time. Every 7th of the month, a report for the previous month is submitted. When do we get the response about our data? How does it inform decision making and changing such modalities? If we think about real-time monitoring of our data analysis, I think we can change something about these modalities. How about the predictive analytics? Can our data give us trends, what we expect in the near future or in the long-term plan? Is it predictive? If you see that every month we have a particular curve of a graph, what will do about it? You will go to the walls of the facilities and the curves are there. Why do you use these curves to inform us to make decisions? So if we imply precise things, and there's organizations report like predictive analytics, I believe this burden of maternal and child health can be tackled. Community-based interventions. Many times, the policymakers bring down policies and the people reject them. Why? Do we involve them when they are making these policies? Do we get their views, or we just push things to them? If we put community interventions, we have leaders. What is their role in maternal and child health? If you have a councillor, you have a member of parliament, we have chairmen on the villages in Africa, from the village up to the nation, we have committees. What is their role in maternal and child health? Don't you think that if we gave the chairperson of our village as a government a car, and we fill that car, we can be able to bring patients or clients to facilities than waiting for the ambulance? There was a program, it's a program where I was working, and there was a non-government organization that put a hiring mechanism for, call them taxi drivers in the villages. And this would be like special hired drivers. So, every health worker in the community and the mother were informed. If you have any health problem, you call this number, the person comes and takes you to the hospital. At the hospital, he gets paid. And it was helping, because the people would bring it knowing they're going to be paid. And they're within the community. You're not waiting for an hour. The moment you call them, they are around. They will bring the patient first to the facility and will save this life. But they're going to call an ambulance. One, if you call an ambulance, is the fuel there. They're going to begin negotiations. Like where I come from in Uganda, they're going to begin negotiating. You are called an ambulance, yes, but there's no fuel. So, me who's calling for an ambulance, they're asking me for the fuel. The client I'm going to transfer has no money for the fuel. So where are we? You understand? So that's why, but if you had someone at the area there who is going to use less money to transport this patient to the hospital, we can save the situation. Partnerships and collaborations. This is not only the health sector. We cannot, as we saw, the determinants of health is a number of things. The ministries, you will see that nutrition is key in shaping the future health of the mothers. But is the agricultural sector knowing this? Are we having the food that we need? How far can the sector go into preventing malnutrition that will save the mothers of the complications tomorrow? How about the private sector? How about the security sector? Do you think it is easy now to save a mother in the Gaza Street? In the war-torn areas, how do we save those mothers? We need a collaboration of a number of agencies, a number of ministries, a number of partners to save this. But in most cases, you will find it's left to one, the health sector. It doesn't make roads. So if you have no roads and the mother cannot reach the hospital in time, it's not the health sector. Where the transport sector? Where is the finance sector? If the mothers don't have finances, do we have empowerment economic schemes for the mothers, for the women? Do we have them? It can't be the health do that. Where is the finance sector? Where is the social sector? All these need to come together if we are to be innovative enough to fight this problem. The community engagement, let us involve our community leaders. Let us empower our women. Our partner and the men involvement. How many here are men and fathers in the house? Only two. The rest are fathers. Okay. I'm a proud father. Thank you so much. How many times have you escorted your wife to go for antenatal care when she's pregnant? The fathers. Wow. Thank you. Wow. How many times have you been in labor suit when your wife is delivering? You're not over there. Okay, so the partner involvement. Down there where we come from, many times it is the husbands who refuse the wives to go for the services. And you have been there, you agree with me. But why? You went there last month. If this month you are going, if the next month, for what? But we're not sick. Those are the questions our sisters and our mothers face from their spouses. So, can we innovate in a way how we can involve the spouses in helping their spouses to have these services? I think, personally, I've been, whenever my children have been born, I've been in a neighborhood with my wife. And I've never been with her in the same, but I've been called miles away, and I've been always coming. And every child we have was born in my hands. And the two of us could be there, not even a relative. The two of us. Even that's what we had in April here from Canada. We were the two of us in the Tutiam hospital. And I've been with her because I know, I learned. That's what I tell you, when you go to labor suit, you know the value of your mother and the value of your sisters, what they go through. So as men, as spouses, can we do this? Do you escort them for antenatal care services? Do you get to learn what they need to go through that pregnancy with them? Do you ever advise them to take the multivitamins they give them? Do you ask them when is your next antenatal care visit? And we plan for it. If we have such innovations, I believe we can bring such mortalities down. So our innovative birth and emergency kits. In the community there, if a mother is going to deliver an emergency, do we have such portable kits that someone can help? The CEO told us about a story, how a husband became the surgeon and became the midwife, and in the long run, lost the wife, lost the child. Because such emergency kits are not available to help us to save these mothers before they reach the hospitals. So I want to talk about those innovations, and I want to tell you that there are challenges about them, but those cannot deter us from embracing them and implementing them. So a few challenges with mobile health technology, we all know that our infrastructure development is not good, and this goes to the government and the policymakers. If we are to use this, we need good IT infrastructure. Resistance to change. Resistance to change. A person like me, I still like physical meetings, not online meetings. What am I telling you? Resistance to change. It takes us time to change. We are not used to this until COVID came. So, you find that you are going to bring an app and people are going to reject it because they don't want to live from their traditional way of doing things. There is a language barrier. Of course, most are going to be in English. How many want to speak English? So it becomes a problem. Then poor network coverage, infrastructure. Then funding, it can be a cost to be running on your phone data and because of these apps. So these are some of the challenges that they're going to face. Community health workers, some of them, they're great resource, but some of them, their knowledge, if they're not having continuous professional development, their knowledge come down. Someone who came knowing the danger signs of a baby after 4 or 5 years, no longer remembers 2 out of 10. So they begin to decline. And then there's a breakdown in communication. You want to reach the mother, but their phones are off, there's no network, or they don't have electricity. So these are some of the challenges. Then sustainability of the community health workers visiting the mothers is sustainable. At times they run out of funds because of our government's not sustaining them, and they become a problem. So on Sunday I was reading that at times they could fail to identify the mothers when they just delivered. Mothers go to the hospital and deliver, but the community health workers won't identify them as fast as possible in the first 7 days. Task shifting. You take a community health worker in the community and it becomes a nurse, leaves the community work, goes to do nursing care. And they leave what took them to the community and they become now pure on the other side. So the mobile clinics, sustainability of the funding becomes at times a problem. And then the seasonal weather changes. I don't know how many of us can run a mobile clinic in winter when it's snowing everywhere, because it's not so easy. So even back home when it comes to rainy seasons, because we do it in open places, in most cases, it becomes a challenge. But this don't deter us from implementing the mobile clinics. So success stories, I won't dwell much on this. This was from Uganda, about home visits by the healthcare workers, and it was about informing them danger signs in pregnancy, danger signs of mothers, come for visitation, referrals, and all that. Is it implementable? Yes. And the collective just showed improvements in mothers' knowledge of danger signs with the preparedness, management service utilization, and the newborn care process, such as putting nothing on the code and the natal care utilization for the 4 recommended timers. So mothers know that when the baby is born, for the code to dry, we've got to put cow dung, ash. But these are the causes of neonatal tetanus. Now, when you bring such community health workers in the community, they teach them, no, that's wrong. This one can dry without putting anything on it. So that when these community health workers were put in the community, they were able to do something. And they were able to have natal care attendants, the mothers, and the project observed that more among the women in the intervention arm who were able to visit by health workers were able to deliver in the hospitals. So if you implement such a strategy, I'm telling you, you can have improvement in the maternal and child health. And then the information and reporting. It is seen that the information the community health workers had was different from the information at the health facility about mortality. And it's very easy. When a baby dies in the village, they don't report the health facility. They bury the baby. So we don't know how many babies die. Actually, I believe that even we are seeing that we have a big problem, but I believe even some mortalities are never reported. I don't know about them. So information, we are able to report higher level information. There were fewer deaths at the facility reported, but the community had more deaths. So if we have community health workers, they can inform us more of what we receive where we are in our health facilities, which is a big thing for us. So in conclusion, irrespective of the challenges to the innovative approach to increase maternal and newborn child health, embracing the innovative approaches such as mobile clinics, telemedicine, results-based financing, or performance-based financing, and others is the only way we can cap down preventable gross maternal, newborn, and child mortality. Thank you.
Give it up for the good doctor.